Hi, my name is Katrina Silva, and today I'm presenting an 81-year-old female with a chief complaint of multiple falls. So some of the things that I think it could be right off the top of my head would be a mechanical fall, such as someone who has a lack of glasses or non-skid footwear, if there's area rugs in the way, or cords, wires, things of that nature. It could also be polypharmacy, TIA and stroke, Parkinson's disease, as well as normal pressure hydrocephalus, or syncope secondary to AFib. So I'm going to go in and talk to the patient, and she tells me that this happened this morning. This is the second time this month that she's fallen. She was getting out of bed, going to the bathroom, she fell, and she endorses no loss of consciousness, but she does tell me that she has been forgetful over the past 3 months, and her daughter also tells me that she has noticed her mother has been walking slower over the past 3 months as well. She lives with her daughter, so her daughter was able to find the patient within 5 minutes of her being down, which was great. Her pain is in her left leg. She was caught in between the nightstand and the bed. There's some bruising, and she tells me it's about a 5 out of 10 on a numeric pain scale. There's some radiation down the leg, but not to the ankle or foot, and there's no edema or bruising in those areas either. She does tell me that walking makes it feel worse and ice makes it feel better, and that it's been 3 hours since the fall, and then she was able to come in immediately. The family history tells me that the patient's father had hypertension, COPD, and was a 30-pack year smoker. He died at the age of 85. Her mother had hyperlipidemia and Alzheimer's. She died at the age of 80 due to breast cancer. She has a sister who's 83 years old and alive. She also has Alzheimer's, hypertension, and hyperlipidemia, and a brother who's 85 who also has hypertension, hyperlipidemia, COPD, and is a 30-pack year smoker as well. On her mother's side, her grandmother has an unknown medical history, but she does know that she died at 72 due to a stroke. Her grandfather has an unknown medical history, but she knows he died at 78, unknown cause. On her father's side, she was estranged from her father's side of the family. He didn't know them either for very long, and she doesn't know any medical history about that side of the family other than her father. Childhood conditions include a hospitalization for tonsillectomy in 1953. Again, she was hospitalized as an adult in 63 and 65 for the birth of her son and her daughter. And then again in 1990 for the passing of multiple kidney stones. This is when she was diagnosed with hypertension. She tells me when I review her musculoskeletal system that she does endorse joint pain and joint stiffness. She was diagnosed with osteoarthritis at the age of 63. And then she also tells me she does have muscle pain in the lower back, but only when she's sitting down for long periods of time, or she sleeps in or is lying down for long periods of time. Her social history tells me that she never drank, never smoked, never used any illicit drugs. She does use Tylenol and Lipitor, but that's it. She tells me that she is widowed and she has never had any history of STIs, past or current. She only had one sexual partner throughout her lifetime, her husband, and she stopped being sexually active in her mid-60s. She wasn't sure when. She also tells me she was a seamstress for 38 years. The last 10 years she worked in her home, so it was always a safe environment, and that she now gardens as her hobby. Her daughter has a cat and a dog where she lives, and she spends a lot of time with them, and her last travel was to Florida at the age of 68. She hasn't traveled since then. For her self-care, she does have a yearly physical. She gets the flu vaccine, pneumovac, and has been vaccinated for COVID ×2. And then she also gets a yearly breast cancer screening since the age of 40, and that continues on as well. No military involvement either. So now that I know this information, I'm going to go to my preceptor and tell her that I believe the patient has normal pressure hydrocephalus, but I'm also going to screen her for syncope secondary to AFib as well. So talking about NPH, the fall itself is sudden, but the disease progression takes multiple months for people to notice a difference. The onset for syncope secondary to AFib is obviously pretty sudden. So when we talk about risk factors for normal pressure hydrocephalus, males and females are equally at risk for this. We have secondary and idiopathic. Secondary is less common, and it's susceptible to all ages. Idiopathic is more common, and this increases in risk as your age increases. Some other risk factors include those who already have congenital hydrocephalus, any type of cardiovascular disease such as hypertension, coronary artery disease, or peripheral artery disease, patients who have a periventricular white matter disease, anyone who has a decreased absorption of cerebrospinal fluid due to arachnoid thickening, and anyone with Alzheimer's or dementia. So risk factors for syncope, I broke down into two sections, just syncope and then those for AFib, so we can screen for both. So the risk factors for syncope alone are reflex syncope, orthostatic hypotension, cardiac arrhythmias, as well as structural cardiopulmonary disease. And then when just talking about AFib alone, we have hypertensive heart disease, coronary heart disease, and rheumatic heart disease, which is more seen in third world countries, so we don't have to worry about that today. Signs and symptoms for NPH. We have the NPH triad, which involves gait disturbance. This is the number one symptom of NPH. This involves small, slower steps with a wide gait, and then cognitive impairment, which includes a decrease in attention and concentration, as well as a decrease in executive functioning and an increase in apathy. And then urinary incontinence, which will first start with the gait disturbances, not being able to make it to the bathroom, and then will progress into apathy about getting to the bathroom. And then another important thing to take note of is the absence of signs and symptoms of intracranial pressure. So the patient will not experience any headache, nausea, vomiting, visual loss, or papilledema. And upon lumbar puncture, they will have a normal opening pressure at the lumbar cistern. When we talk about signs and symptoms for syncope, the patient's going to be feeling lightheaded, they may feel warm or cool, they may start sweating, have palpitations, they may lose some vision or have tunnel vision, they may lose hearing or hear whooshing sounds through the ears, and they will appear with pallor. So specifically cardiac-related signs and symptoms will be structural heart disease, any major EKG abnormalities, syncope while lying down, syncope after physical exertion, and any kind of syncope that's preceded by palpitations are all indicators that this may be related to AFib. And then now that I want to prove my patient does have normal pressure hydrocephalus, I'm going to go ahead and confirm this diagnosis by first ruling out other diseases and making sure there's no other underlying cause, such as Alzheimer's. So we want to check a vitamin B12 as well as a thyroid panel. And then really the way to to confirm this is looking at the signs and symptoms and doing a physiological assessment. You don't want to do mini mentals on these patients because you're going to miss indicators of the disease. And then when testing for syncope secondary to AFib, you want to do a couple of things. So get a health history, do a physical, you want to check an EKG and TTE. You also want to do lab work, checking for A1C, a CBC, a creatinine, and a T3 and T4 to just rule out any other causes that are not cardiac related. So that's why I believe my patient has normal pressure hydrocephalus and not syncope secondary to AFib.